Hello, everybody. Thank you for joining. Thank you for joining another session presented by the Dental Laser Integration Study Club. I'm Elaine Rodriguez. I'm the host and the moderator for tonight's session, and I am hosting Miss Danielle Ratcliffe. She is an awesome perio hygienist. She uses endoscope, she uses laser, and she's just highly specialized with a lot of many years of experience. I also met her through Oral Systemic Mastery, Dr. Tom Larkin's event that he held in Lexington, Kentucky earlier this year. And I'm so excited to be able to bring her knowledge, her passion, her intuition to be able to present this to us tonight. And as you guys know, I am very dedicated to bringing speakers that are in the everyday clinical trenches, working with technology, working with people, working with challenging people that have some expertise to teach us and show us. So I'm very excited that Danielle is here. Thank you, Miss Danielle. Um, a couple of housekeeping items, guys, just to get the boring stuff out of the way. So we are going to be providing your CE credit for attendance within 24 hours. So whatever email you signed in with from this program, that will be emailed directly to you, both from the Zoom email and also from my personal email, which is coming from info@dentallaserintegrations.com. I'm going to put that in the chat box, okay? So info@dentallaserintegrations.com. Okay. And again, your one CEU document will go out to your email within 24 hours. Okay, so by this time tomorrow. So everybody, can you guys put in the chat box, where are you coming from tonight? I'm in Scottsdale, Arizona. Miss Danielle is in Idaho, Idaho Falls, Idaho. Where are you guys all joining in from? Go ahead and put in the chat. Boulder, Idaho Falls, West Virginia, Tucson, Arizona, Minneapolis, Colorado. Love it, guys. Love it. Okay, so I'm going to go ahead and stop my share. And let me triple check that we can see your screen, Miss Danielle. Yes. Okay. Miss Danielle, thank you so much for being here, and please take it away.
Thank you so much for having me, Elaine. So tonight we're going to be talking about endoscopy or the endoscope, and it's titled Beyond Blind Scaling, Mastering the Periodontal Endoscopy for the Modern Hygienist. Essentially giving information that you may already know, or things you may not know. So a little bit about me. I'm a periodontal hygienist currently. I graduated in 2013 from Colorado from the Community College of Denver Dental Hygiene program. And I've had various different jobs before I got to the role of working in a periodontal office. If you would have asked me when I graduated school, would you ever work in perio? My answer probably would have been no. Um, it's definitely the most challenging thing I've ever done in my career, but I absolutely love it. I feel like every experience along the way and every person and hygienist and dentist and even assistant that I've worked with have all shaped me to be the hygienist that I am today. And so I feel like each job along the way, even though you may not know your purpose or role in that job, if you're happy and loving it or maybe not happy, will shape you for the next part of your career. And so that's something really exciting to where I'm finally at a point where I feel like I have all the knowledge that I've gained over the years to really help people. So even though I live in a smaller town in the eastern slope of Idaho, there's only 70,000 people. It's still a big town, and where we're helping people all around, a 3, 4 mile uh, 3 to 4 hour, I guess, radius because um, we are the biggest town on the eastern slope, and so there's a lot of people that come to see us. There is one other periodontist office. I take that back. Two other periodontist offices in our area. One other one uses the endoscope, so that's pretty awesome. Some of the information that you learn in continuing education, I guess most of the information you learn in continuing education and courses and webinars are all tools in the toolbox. So they're all things that can help you along the way in your career. If you take a course about myofunctional therapy, about the endoscope, saliva testing, each little thing that you hear it once, it sounds interesting, and then you take another course and you hear it again, and eventually it becomes the norm in dentistry. And so I'm really hoping that whether this is the first time you've heard about endoscopy using the endoscope or you've heard about it a lot, that you can share the information with others so that this can become a regular thing in dental offices, a regular piece of technology, just like going from, this is a simpler analogy, but hand scaling to ultrasonic technology, it over time was able to become integrated in. So being able to share the information is awesome. And all thanks to Elaine, because we just had a simple conversation, like she was talking about in Kentucky, about what I do. And I just thought it was normal. I just use the endoscope to treat patients at a kind of higher level of care when they've exhausted their other resources with their hygienist. And I kind of talked about that. The experiences along the way will kind of help you to shape your career. So talking about who do I treat, I'll talk a little bit about the endoscope itself, all of the specific details of what it is, give some examples, show some videos. But it's not just about the endoscope. That's just, again, a tool in the toolbox. So there's so much more to being able to treat patients in that more comprehensive way. So who do I treat? I kind of talked about that. All ages. So I'd say most people that come to a perio office are between the ages of like 14 and 95. You know, we accept all referrals. We'll talk to all patients and give them the opportunity to, I guess, share their side of the story and let them know how we can best help them. And then they decide if they want to move forward with treatment. I'd say the most patients that come to our office do move forward with treatment, utilizing the endoscope. The patients that don't, usually it's a financial. So sometimes that just takes them a little bit extra time and we can help them along the way. What do I treat? So in a perio office, some of you may already know this, some of you may have no idea. When I was in a general office before, I actually had no idea what happens when you send someone to perio. I just knew they came back in a year and most of the time they were better, sometimes they weren't. That is something that I wish I would have asked more questions and learned what my local periodontist office in Colorado did. But we do deep cleanings. I do deep cleanings. I'm the only hygienist. Deep cleanings would be the SRP with the microscope or the endoscope, LANAP with the endoscope. I complete the SRP portion of that, and then my doctor, Dr. Moulton, he completes the laser portion of that. So we work together. That way you can have that, complete treatment. And then there are times when he can perform the flap, and I can complete the deep cleaning or the scaling and root plating part of that, still use the microscope. So even if you were to flap a tissue in a difficult area where the microscope might not fit, that just gives you more access for the endoscope to fit all the way into the pocket. And usually we can tell that information from the CT scan, from the records that we gather. In the beginning at the exam, we'll talk through that and determine, is this patient going to be a good candidate for the endoscope? Would it be more efficient if there was a flap also? But we want to keep in mind healing. And the less that you can cut or move tissue away, the better chance you'll have for that laser to help regenerate those soft tissues. And then perio maintenance. So my schedule is pretty much full of deep cleanings and perio maintenance. I don't do any prophies. So. And we do let patients know. Some patients call us without a referral. I just moved to the area. I was referred by a friend that sees you. I would love to see your hygienist for a cleaning. Could you help me out? And we support them by recommending they go back to a general office in our area, and then we see where they live. So just the perio maintenances. And I'm sure all of you know, can you do it alone? In some states, yes. In Colorado, for example, you can be a hygienist and have your own practice. But personally, with the higher level of care that I provide in this office, no, I can't do it alone. In a perio office, there's so much that goes into on the back end of treating these patients and all the things I'll talk about later. So I have an awesome team. Love going to work every day. Love working with all the girls and Dr. Moulton. And I feel like your team is super important for making it a great working environment. And your patients can feel that emotional energy too. So that's something that's super important because our patients that come in see that we all work well together and that we all get along. And that feeling comes across to them also. So um, we do more than obviously just deep cleanings in a perio office, but I could talk about that at another time. I'll talk a little bit more in detail about what it looks like in an exam, what things we look at, but to kind of give you a brief synopsis, removing all of the debris under the gums with the endoscope, what we're here to talk about tonight, is very important, but also looking at so many other things of how they got to the point that they, I guess, are in now of their advanced gum disease, whether it's early stages or advanced, is important for healing. So just like any tool that you have in the toolbox, can you do it with just one tool? No. Can you just use the endoscope and your patient is back to healthy? No. It is a great tool, but you do need to take a look at other things along the way. So saliva testing, looking at labs, their systemic labs, working with their medical provider can help to treat patients a little bit more detailed also. Our exams are about 90 minutes, and during that time we're record gathering, and only a small portion of that, when Dr. Moulton comes in for the exam, is actually explaining the procedure. We less explain the details of the procedure and more explain how we can help them, letting them know that their hygienist does a great job. I always make sure to support all the regular offices, letting them know your hygienist does an amazing job. Some of these areas are really hard to reach. They're microscopic, they're teeny tiny, and you can't remove what you can't see, and you can't remove that's in a little hiding spot. And so we support them by using this microscope or using this endoscope to magnify and see underneath the gums. It's very comfortable, and it is something that will help you to heal. And so patients really appreciate that. I have learned over the years, and any of you that are watching that know me, that I am an overthinker, and I tend to talk quite a bit. And so I've learned over the years to keep it more simple for patients, and the more simple that you can keep it, the better it goes. So, I cannot diagnose in Idaho, so I do have to be very careful about the way that I talk to patients. I essentially let them know how we can help them. I always use we, and then, and I'm sure all of you know in the states that you can diagnose and cannot, what Dr. Moulton will most likely talk to them about when he comes in for the exam. So. And then the learning objectives, I won't read through all these because I'm sure signing up for the course, you kind of looked through these 4 different learning objectives to understand if I'm going to listen to Danielle and Elaine for the next hour, what are things that I'll take away from this? And I definitely want to make sure at the end to answer any questions. If there's anything you think along the way that is like a burning question that you think, I don't want to wait till the end, I need to know right now, just let us know. Just type it in the chat and I'll be able to, Elaine can help me to field those and I could answer them. But essentially, we're going to talk about the endoscope, how um, the talk in detail about the different parts of it, how it can be incorporated into your specific office, and a little bit about how to understand what you're seeing. So, for those of you that have absolutely no knowledge, what is the periodontal endoscope? It is a microscope, so it does magnify. This picture shows what one of the brands looks like. It's a computer screen, so you can see it's a touch screen, and that picture is actually a picture of a tooth. On the left-hand side of that screen, there's a camera button, there is a recording button. So some of the videos that I have taken are when I am treating a patient, I think, oh, this is going to be great for their chart to either show the patient, depending upon their personality, or to save in case their provider wanted to know, if there was a fracture or what the buildup looked like under the gum line. The blue part that is underneath that screen is essentially I guess, part of the computer where the uh, laser fiber cords plug into. That's also connected to the water. And then obviously there's a stand. At the bottom, there's a standalone water bottle. So that can be connected, or excuse me, that could be standalone. So you can put your own water in, or there's lines that can be connected to your dental unit. And then on the side, you can barely see it. I'm going to have a lot more pictures that are way zoomed in. There is the actual little microscope handle with a little teeny tiny fiber, and it is on wheels. So if you have a question of, well, is this feasible to move from room to room if there's multiple hygienists? Yes, it is very easy to move. It is delicate, and you do have to be careful rolling it. You'd never roll it with the fiber on, but you can move it. So the endoscope is a magnified camera. It is able to show a camera image by using a little fiber optic. And there's a little teeny tiny crystal that reflects that fiber optic, and that's how you're able to see. So when you're in a dark environment like the gum tissue pocket, the light that shines out of, I guess, the refraction of the fiber optic is what allows you to see down below the gum line. So this is this is a picture of me. It's giving you a reference of how big it is, because in that other picture, it makes you think like, how big is this? Is it really small? So depending upon the size of your operatory, I kind of took a picture of my room of how big it is. And so it looks pretty tight, like there's a lot of stuff in my room, but I actually feel like I have quite a bit of room. It sits on, for me, it sits on the other side of the patient. It's just a little bit easier for me to pull the endoscope fiber or the sheath across the patient. And when I'm not using it, it actually lays on their chest. I don't have any pictures of like actively working on patients just because I guess I just don't have any pictures of that. But that gives a little reference of how big it is and where it could fit into the room. So, and then when we're not using it, I store it in the corner just so that it's out of the way. And you can see, I'll go back. So on the picture on the left, right by my left hand, you can see where there's a teeny tiny little pen, and that is the actual fiber sitting there. If I am not using the microscope, excuse me, if I'm not using the endoscope, that fiber is always taken off and it is in its protective case. That is the most delicate part that can be, I guess, it can be bent just because it is a fiber optic. So this is stored in the corner. All the cords are nicely wound up, and so it looks nice in the corner. And then I do use a PTB woodpecker, which is an air polisher, and that's sitting up at the front. So with the endoscope, I solely use an Acteon piezo. There are a lot of different ultrasonic brands. There's a lot of different piezo brands. I was trained and I was taught by a hygienist that really helped to introduce the Acteon piezo with the different tips. So right and left, straights, slim lines, and then I actually utilize 4 hand pieces during a deep cleaning, so that way I am not constantly having to use a little wrench that's on the left and switch out all these tips. So I actually have a total of 5 hand pieces that I'm running during a deep cleaning so that I could be most efficient with the endoscope. This is one of the things I was talking about with being able to keep it protected. The endoscope sheath, excuse me, the endoscope fiber always lives in this box, this little padded foam box. That's what it came in. Um, it either lives there or it lives on the endoscope when we're actively using it. And it's got a little cover that the fiber can be protected in before it even goes into that box. And on the left, that gives you an example of the sheath that the fiber optic runs into. So it comes sterilized, and the little bib clip kind of gives you an example of that. So the actual fiber inside of uh, the endoscope that was on the right is actually really small. So it's only 1 millimeter wide. It's very delicate. In previous companies, I've actually broken them before, and they're quite expensive. Just by the fiber optic bending or I guess tipping at its weak point of where it meets the machine. So different companies and the company that I'm using currently, PerioView, they have worked on the technology to support the end where it is that weak point. And there's different ways that it's held into the machine so that it is as supportive as possible. And so this fiber I think I've had for about 3 years. And I take really good care of it. So try to be really careful with that. But you can see, for example, the actual fiber itself is that white part. Mine is black, but that's the white part. And then at the very tip, you can see the light shining. That is where there's a little crystal in the end, and it actually refracts the light so that when you are in the periodontal pocket in a completely dark area and you're trying to magnify something, you can see it.
Miss Danielle, we have a question.
Sure.
How often do you have to replace the fiber?
So you should never have to replace it unless it becomes damaged, as long as you take care of it in terms of um, each sheath is disposable. So you take the sheath off, you put the protective cover back on the fiber optic, take it off and store it in the box. It should never become damaged. And my recommendation is have one person take care of it. So if you're a single hygienist, you be solely responsible. If you're in an office with multiple hygienists or multiple assistants, or you have people helping you clean your room, for example, in my office, the assistants, if say Dr. Moulton is using the endoscope, the surgical assistants will let me know, hey, Danielle, we're all done with the endoscope. And I let them know, just put it in the corner. I'll be in there in about an hour. And so I'm the only one that actually cleans it and takes it apart just so I know how to, I'm very delicate with it. So you should never have to replace it unless it gets bumped or damaged. I say
And
bumped, meaning like someone bumps into the machine if they're in your room and that fiber is damaged.
and just to be clear, Miss Danielle, there's the actual fiber optic cable, and then there's a protective sheath that goes over it that is a disposable, and that does get replaced at a certain after how often?
So on the right-hand side in the little foam box, that is the protective cover that lives over the top of it when it is not inside the sheath that's on the left. So on the left is the disposable sheath. They're one-time use. So one per patient, single use only. They come sterilized from the factory, but they are not sterilizable. And you obviously can't share them between patients because it's going down underneath the gum line. And then there's water and biofilm that would be in that line.
Thank you.
I
And you're
don't have
doing
a
great,
picture.
by the way.
Okay, thank you.
If
I don't have a
everybody's
picture.
enjoying it, please give us a little
Okay.
happy face in the chat. Thank you.
I don't think I have a picture of what the fiber looks like unprotected, uh, just because, like I said, I've broken one, and I don't remember the exact cost. in the past with a past company that we use that's now out of business, but I believe it was a couple $1,000s for that actual fiber. And so that was a very tough conversation to say that we're going to need a new fiber. So I treat that like gold. So the fiber optic camera, you use it by inserting it into an actual Explorer. This is kind of a zoomed in view. I know you couldn't tell, especially because we're on Zoom and it's on a video screen. I'm sure some of you are watching this on your phone, so everything's teeny tiny. The fiber is inserted into what I tell patients it's inserted into a pen. So I try to make everything sound less scary for patients because an explorer, they think, well, what are you going to explore and what are you going to be doing and looking at? And most patients that come to see us are already nervous and anxious. And so I try to use the most simple terms possible by saying, you know, the little fiber is inserted into a little pen and that goes down in between your gum tissue and your tooth. But it is called an explorer. Um, and in the kit, it does come with four. I have a picture of those coming up. And it depends upon what tooth you're on, just like a hand scaler or just like maybe a right and left, depending upon where you're at in the mouth, what tooth you're on will depend upon which explorer you use. And that comes with training and that comes with experience to understand of which one to use. But you can see, similar to, I guess I can compare it to an anesthetic syringe. When you are looking at an anesthetic syringe, or I guess the needle, there's a bevel. And so the back of the bevel is actually what is going to be pushing the gum tissue out of the way. And then the open part is what is reflecting against the tooth, which we'll be showing coming up here. And the actual fiber slips into the back and goes through into that opening. And you can see on this screen, the Explorer has a little round dot in the back of that, I guess, like machined metal part. On the actual sheath that's disposable, it has a bump. I guess it's made out of silicone, and it almost has like a little bump, so it cannot go farther in, meaning it's like a lock and key. The fiber, once it is inserted into the sheath, can be placed into the Explorer, and then it'll go into the Explorer and it sticks. And the little bump allows it to sit in the little hole of that Explorer, and then it just stops. And so that allows you to know that you have it in the right spot. So it's pretty easy to place it in, but that just helps to ensure that you have it in the right spot. So this is an example of, I guess, how it would fit in your hands, just similar to any type of, whether you're using an ultrasonic or using a hand scaler, and you can see the sheath that's protecting the fiber pops out of the Explorer and goes into the little metal portion of the Explorer. I don't think you can see too well with the bevel, but the bevel's open and up on that left-hand side. And on the actual endoscope unit, the side of the endoscope unit has a little Explorer holder, that little white piece, so that when you're not utilizing it, I actually lay it on the patient's chest when I'm actively completing a deep cleaning because I'm constantly going back and forth between the Explorer and the piezo, Explorer and a piezo, or sometimes both at the same time. I wish that I could have had a video showing you using them all at the same time. There is one little video that I'll be able to show you of a clinician, Karen actually, utilizing it with the patient, but I don't have a video showing. But you can use it at the same time as your ultrasonic, or you can use it alone just in the pocket. But that's usually where it rests and sits, just for safety, because again, that weak point is right where the laser fiber comes out of the machine. I want to point to it, but I know you guys can't see what I'm pointing at. So this is an example of the four different types of explorers. And again, different explorers for different parts of the mouth, whether it's anterior, posterior, you know, just like hand instrument, you can use any Explorer at any angle that you like, whatever fits the best. So sometimes I might use what looks like a bended posterior on an anterior tooth if it's really difficult access. So I would say the training that's provided from um, when you purchase a endoscope will teach you how to use all of them and where to use them in the mouth. But just like any training or in school, you can always use them however it works best for you to be able to see. So one of the most important parts that I didn't talk about is how can you see underneath the gum line when there's crevicular fluid, there is blood, and most of the time if you're doing a deep cleaning, even if they've been numb, um, there's bleeding. And so in order to be able to see, you have to have water flowing through that sheath. I don't think I have a good example in the picture I can look back through, but on the actual sheath that was sterilized, there is an open port that the fiber fits into, and just alongside of it, there is an open port that is actually screws right into the back of the endoscope, and that is where the water flows through. And so it is completely separate, meaning there are two uh, I guess, ports that are on the little disposable sheath so that the water is flowing through alongside the fiber, but it never touches it, meaning that fiber stays completely dry. Uh, I always touch the fiber with a clean hand whenever I am placing it into the sheath. And so it never needs to be wiped down with any type of chemical, any type of cavicide or anything like that, because it is not ever exposed to the air, to the environment, to bare hands. I always use a glove when I'm putting that on. And so the fiber never actually, I guess, sees the inside of someone's mouth. It never goes into the pocket. It's always protected by that sheath. It's completely protected. So the water flows through separately, and that is controlled through a foot pedal. And so the foot pedal has a steady flow. You can control the off and on just by similar to like a rheostat. You just hit the foot pedal. Once the foot pedal is on, the water continuously flows. Um, and again, I talked about that briefly at the beginning, but you can utilize the standalone water bottle if your unit, if it's too far to plug an extended water line in, or if you don't have the opportunity to, or yeah, I would say if it's too difficult, you can plug it into the demo unit. So I was going to get the name of the previous company we used, but I can't remember the name of it. When I started at Dr. Moulton's office in 2022, they were utilizing the endoscope. There was a hygienist before me, and she had extensive training on the endoscope, and she had been using that for patients also. The company had gone out of business, and so that's why we currently have this PerioView endoscope. There was a little bit of manufacturing change to where even though we have an older endoscope, there are no longer supplies for it. And so the endoscope that we currently have is only about 4 years old, but Dr. Moulton has been utilizing this technology for quite a long time. So PerioView and then Zest Dental Solutions. I don't have a picture of the Zest endoscope, but those are the two companies that use it right now. And this video does not have the sound to it, so I'll kind of talk through it. But this gives you a little example of some more details about it. So this is an example of working with a patient, how you would utilize the endoscope with your patient. Like I said, you can place it wherever you like. You can, depending upon if you're left-handed, right-handed, you can place it next to you. You can place it across from you. Ergonomically, it's best if you place it across from you because you are looking up at the screen while you are utilizing the endoscope and the piezo. And so that is one skill that is really interesting and really fun to learn is you're no longer watching the mouth that you are scaling. So that's really interesting. You are watching a computer screen. So you're sitting straight up, looking at the computer screen, scaling because you are watching the screen to ensure that you are removing that calculus or that biofilm off of the screen. Obviously, you're going to pause, the patient's going to move, you stop what you're doing, and you're looking down. But for the most part, once you're in the pocket, you're just looking forward at the screen. So from an ergonomic standpoint, it makes a lot more sense to have it across from you, similar to that picture that I showed in my operatory where I have it on the other side. And everyone's a little bit different, but because I'm a perio office and I'm doing deep cleanings that are very intense from 4 to 11 millimeter pockets, and I'm working very efficiently for a long period of time, I actually take the Explorer and I let the patient know at the beginner, I ask them permission. We use a sterilized towel across their chest. I ask, is it okay if I rest this just right on your chest? Just because I need to pick it up, put it down, pick it up, put it down. And ergonomically, it would be too much for me to keep going across, put it in the pen holder, looking above my loops. So I prefer to rest it on their chest. And for the most part, patients aren't going to move, but if they're kind of wiggly, I definitely set it back into the pen holder because, again, that weak point is where the fiber goes back into the machine. And so if it were to kick down or a patient were to move their arm, they could damage the fiber. Um, and so and this is Karen from PerioView. On her right hand, you see she's using her ultrasonic or her piezo, whichever you prefer. And then the left hand, she's utilizing the endoscope. And so usually your dominant hand is always going to be your tool that you're cleaning with, and your non-dominant hand will always be the endoscope. If you are just looking for observation or to check to see if everything's gone, that's when I set the piezo down or um, your tool, and then I'll use the endoscope with my right hand. So 2 foot pedals on the ground at all times. Right foot pedal controls your right hand, left foot pedal controls your left hand, except for when you are switching it up and you're actually using the endoscope by itself, then your brain has to remember my left foot controls my right hand. So every once in a while, the patient gets wet because, your brain has to switch back and forth. And sometimes that water can shoot out across. So sometimes it's kind of funny. Um,
Danielle,
uh-huh.
let's take a moment and just appreciate like the ergonomics, the precision, like the instrumentation, the body positioning that is going into this. And then by the way, my patients get wet on occasion as well, even with the Cavitron. Um, and so you have literally both instruments in the pocket at once. So even
At
just
once. Mhm.
maintaining that depth of insertion. And I would guess that the probe itself or the camera itself is at least 14 to 15 millimeters. What's the depth of insertion with that?
I would say it depends upon the pocket and what you're seeing. So
Okay.
if you're working with a 4 millimeter pocket, the angle, because the actual Explorer is, I guess, skinny. It's skinny at the end and then it gets wider. You're not going to be able to insert it very far in the pocket if it's only a 4. So you might insert
Okay.
it at an angle to get that reflection. So you're
Okay.
not inserting it too far. If you're working on a 7, 8, 9 millimeter pocket, a majority of that, like you mentioned, 6, 7, 8 millimeters are going into the pocket, but that perio pocket is so stretched out that
Hmm.
it is comfortably fitting down under the gums. Obviously, the patient is numb, but
Yes.
you're not pushing tissue back, you're not damaging tissue, you're not stretching
Hmm.
it out more than it already is. So similar to your ultrasonic going into the pocket where you feel like you could efficiently clean without stretching the gum tissue, for lack of better terms, the
Hmm.
endoscope can fit in there just the same.
So, and light travels, right? So it is illuminating the area. And also, how is it looking straight ahead? Because I know, some of us who indirect vision and then ergo loops and now, having to look straight ahead, is that something that was a big adjustment for you?
I would say, yes, it was a big learning curve in the beginning. My personality is to be prepared. And so, not understanding how to fully use it, I was a little nervous in the beginning. But after you treat one patient, it all comes together and all of the, I guess, paperwork training makes a lot more sense. And then it's just practice, just like anything going from school of learning how to clean someone's teeth and it takes you 4 hours and now you get it done in an hour. Similar to the endoscope, it is a little bit of a learning curve. And ergonomically, you're using muscles that you're not used to because you're used to being bent over, unless you have those new loops. But you're used to being bent over, and now you have to sit up and scale and trust that you understand where you're looking. And all of the training that everyone has had over the years, you'd be surprised if you close your eyes and just scale, you can do it. You're a lot more confident hygienist cleaning with your eyes closed than you would think. And I say that because that's essentially what you're doing when you're looking forward, because you're not looking in the tooth to make sure you're in the pocket. You know you have the skills, you know you're great at adapting, and so that's essentially what you're doing when you're looking for it at the microscope. You're adapting it to the tooth, you're using that sense of feeling and knowing that you're on the tooth when you're looking forward.
Thank you.
Um, and like you were saying, ergonomics is important. You could see how straight she's sitting up. You almost have to be able to see through. So if you're wearing loops, you're looking above your loops because this is a magnified screen. I'll play this more of the video. So this is the touch screen part of it where you can take a video. So the red button that she is pressing is actually a video. You can take as short or as long of a video as you like. Um, the top button, the little picture of a black camera, that's a snapshot. So if there's decay, I'll always snap a photo for the general dentist. If there is interesting piece of calculus because as hygienist, that's really exciting. You're like, oh, look, a big piece of calculus. You can take a picture of that. Take a picture of whatever you like, as Vinny. A lot of times, because um, I don't always have access, depending upon the position of the patient, to reach the camera. Like if it's a little bit, excuse me, the computer, if it's a little bit farther away, I'll ask one of our team members to take a couple photos if I know if it's a difficult area or say there's a fracture or anything that I cannot efficiently place the endoscope in, use the foot pedal, have the water flowing, not have the patient move, and reach over and take the picture, I'll ask someone to help. So it kind of depends on what you're trying to capture, but it's definitely user friendly. It saves it right on that computer screen. And because it works just like a Windows-based computer, we just plug a little flash drive into the back of the computer, drag the photos over so that way we can upload them into the patient chart. So ours is not connected to our server. We just wanted to keep it separate because it's a part of this unit and it's only utilized for the endoscope. So this gives a perfect example, Elaine, of what you asked. Um, what's all going in there all at once? In the patient's mouth, they have a saliva ejector coming out the side. I personally prefer a leaf suction because it's using your HIVAC, and it's so much more comfortable to have a silicone leaf sitting, comfortably on the cheek and I'll talk a little bit about time and how long it takes, but these deep cleanings when I'm seeing someone in a perio office is taking me a lot longer than it would probably be in a general office, but it's taking me between 2 and 3 hours per half of the mouth to do these deep cleanings when you have between 4 and like 10, 11 millimeter pockets. on all the teeth, so it takes me quite a while. And I want the patient to be comfortable. That's my most important. Well, I need to be comfortable because I don't want my back to hurt and my neck to hurt and everything, but I want the patient to be comfortable because it is a lot of water. So if you used a saliva ejector, the patient would feel a little bit overwhelmed, especially since they're numb on the whole entire half of their mouth. And so if you're going to invest in the technology of an endoscope, with it, there are different things you'll need to invest in also. And I would say there's a ton to choose from. I personally like the Leaf. Um, but I'm sure there are others that are great that still use that high vac connection to evacuate more of the water out because you have the water from your ultrasonic or piezo and you have the water coming out of the endoscope at the same time. So you can see how it fits into the pocket, both of them at the same time. And then on the right, that is an animation of the what you're seeing in real time of that CEJ in the middle of the screen and then the piezo actually removing all of that debris. So that's kind of cool. And again, sorry that there's no sound on that. First time using Zoom, I could not figure that out, but pretty much talked through it also. So I'm sure some of you are wondering now, like, can I use this? Can anyone use it? It looks hard. I'm not sure. Anyone can use it. I would say that it just takes training. It just takes learning. The company, depending upon where you buy it from, I can't speak for Zest because we don't have one from Zest, but for PerioView, when you are purchasing an endoscope, the training is super important because you're not only you're not only getting the opportunity to understand how to use it, but you're also creating that relationship with a company that has a passion for keeping this industry alive. Being able to manufacture a dental endoscope costs a lot of money. So the endoscope itself costs quite a bit. The sheaths cost quite a bit. It's, I believe, from a patient standpoint, it's about 95 to $100 just for the basic cost of the microscope sheath. And so I'll talk a little bit about costs later when you're incorporating that into passing that along to the patient. But having the training, you're not just getting training and then you're done. You have a support system. So whether you start using the endoscope and you are nervous or you have questions or there is a problem or a hiccup, you always have a support team to be able to call and ask and say, hey, I plugged this in, it's not working. I forgot what you said on this day. Like you're paying for essentially, I guess, a whole package. And so you're going to learn how to use the Explorer, how to use different techniques to use it on different parts of the mouth. Go over everything, kind of what we talked about today. Go over all the different parts on the unit, how to maintain it, how to clean it, how to care for it. So that's definitely included on that. And then I didn't personally have training from PerioView because I had already knew how to use the endoscope for a couple of years before before we purchased theirs. But I do know that they do talk to you a little bit about the verbiage of how to talk to patients. And then on the back end, those marketing, I guess, tools to be able to help implement that in the practice and to, I guess, incorporate the different verbal skills for the front office also. So that's included. And by the way, I know a lot of times when you have webinars or, talk to different people, they let you know uh, quite a bit about certain products because they either are passionate about it or they're being sponsored by it. Like we just purchased the endoscope because we wanted to continue with the technology and absolutely love talking about it. And so that's why I'm only talking about the one. I just didn't have time to do research and talk about the Zest, but if anybody wants information, I could probably find that out and get back to you on it. And so this is just the one I use every day. And so that's why I'm talking solely about this one. Okay, so now here are the things you probably want to see. So I'll go over what you're looking at first, because to me, I totally understand everything that I'm seeing on the screen right now, but for you, it might just look like a blurry blob. So the inflammation is going to be that tissue. It's it's so cool as a hygienist to understand when someone has a deeper pocket, when someone has bleeding, when someone has inflammation, to see what it actually looks like underneath the gum line. And so the inflammation is on either side. How we talked about the endoscope itself and the explorer, to where it's got the back of the bevel that you're pushing the gum tissue out of the way. And so that top part where the bevel is open is what's reflecting the light, and the water is flowing out. And that is the bottom part of the screen, so that it's reflecting up against that tooth. And then obviously it's a magnification, so you're able to see a big tooth. This is probably a lower anterior tooth. I don't remember which video this is. And so the top part of the tooth, the more white part, is going to be the enamel portion. And as the endoscope moves down, some of you may be able to tell, some of you may not be able to see the CEJ, where it kind of transitions into the cementum. And this patient had quite a bit of inflammation. So it was actually a more difficult deep cleaning because there was so much inflammation. So it was a lot tougher to see all the calculus. And so this video was meant to not be super clear in terms of understanding what you're seeing. It's just more of to understand these are the different parts when the bevel of the endoscope goes down, what you're seeing. So play that one again. Okay, so this one is a little bit more interesting because it's actually showing you calculus. So it's going to be flipped. The bevel is going to be at the top of the screen, where the tooth is going to be at more the bottom of the screen, and then the tissues on either side. So right now in the beginning, oh, I'm going to go back and show you how I talked about water is important. So you'll see the curvicular fluid and the blood start to pool. So if you wonder, what does it look like if I don't turn the water on? This is exactly what it looks like in the beginning. So as that blood starts to pool and I guess get in the way of your view, then the water starts to flow so that you have good access. So all of the brown and shiny white are the pieces of calculus that are being removed. And this is looking from the top down. So that's the base of the pocket where the end of the piezo is kind of pushing.
This is so neat, by the way. Everybody in the chat, I mean, Casey Morris, to be able to see that inflamed tissue up close like that is wild. Yes, it is. It's just amazing to see like the black calculus, the shiny. That's so neat. Very cool.
Especially as a hygienist, that is one of the most fulfilling parts about using the endoscope, is that confidence to know that it's gone. And that's one part that I don't have any regrets, but I do know that while I feel like I'm a pretty good hygienist, I know that in my career I have left a lot of calculus behind, because it doesn't matter if you're the best hygienist in the world, you can't remove what you can't see, because there's always microscopic calculus that's left behind in hiding spots, teeny tiny little pieces that may not seem like they're causing too much inflammation. But even those tiny little specks that were left behind, that can, in some patients, elicit that immune response. Um, and that patient that continually has that inflammation, or they're doing all the things that you ask them to do, they're following all the protocols, they're using all of the products, and they're not getting better. Um, Sometimes it truly can be systemic and what's going on in their immune system, but a lot of times it's their immune system response of something that's left behind. And I'm sure that a lot of you know the bacteria, I won't get into too detailed of bacteria today, but the bacteria that are present that contribute to gum disease, whether it's gingivitis or periodontal, I guess advanced periodontitis, they have a home, and their home is the calculus. So by removing that calculus, you're removing the majority of their home. Obviously, they're still in the gum tissue, they're in the bloodstream, so it's not that easy to remove them. But if you take away the majority of their home, then your immune system has a lot better chance at being able to manage the levels in most cases. If not, send them over to us. No, I'm just kidding.
Yes.
Um,
Yeah. Yeah. I
I'm
think
sure.
that's a big one. When to refer, how to refer, how to say, this is outside of my comfort zone. That
Mhm.
it takes a lot. And this is why I'm very dedicated to highlighting speakers like Danielle, who are very humble, but very knowledgeable and can really support us in bridging that connection between where our scope reaches its, perimeter to where they can pick up from where to support that patient. Um, we have about 5 minutes left in the session, but if we go over, guys, a couple minutes or 15 minutes, whatever, I will give you guys more credit for that. Okay. So if we end up spending a little bit more time, okay, go ahead, Miss
Mhm.
Danielle. Sorry.
And I'll do less talking and more just showing, because I know that's probably what a lot of you want to see. So I'll just kind of go a little bit faster through these videos. So I can talk about this more another time, but benefits of using the endoscope, we kind of talked about it. You can directly see. You can't see what you can't remove. Disadvantages of, it takes you a little bit longer, because once you know it's there, you'll definitely want to remove it. So this gives a little bit more anatomy of what you're seeing. This is recurrent decay. So that top shiny part is a cavity, and then the top shiny part is part of a filling, and then there's recurrent decay. So I actually took this photo, sent it over to the general dentist so that they were able to help diagnose, because you could not see it on an X-ray. When should you use it? The one thing I'll highlight, I don't want to read through all these slides for time purposes, but you don't want to use it on a prophy. You definitely want patients to be numb, and you want to be able to be paid for your services in time. And so I would say you utilize it when you're completing a deep cleaning, to give you the best tools to be able to efficiently complete that deep cleaning. And I don't, a lot of us have always said, oh, it's just a 4 millimeter. Oh, we'll just keep an eye on it. It's just bleeding a little bit. Let's just keep an eye. But without an endoscope, you should just assume that all pockets have calculus. So this pocket was a patient that had a 4 millimeter pocket. And at first we thought, they might not need a deep cleaning. But you can see it's right at that CEJ, right where that enamel is meeting that cementum. And he hadn't had a cleaning in 20 years, so his calculus was very hard to remove. This tooth, I'd already removed most of it, but I'd saved a little chunk just to kind of show you, because it was a 4 millimeter pocket. You would have never guessed it. It didn't bleed that heavily, but he had a ton of calc underneath there. And then it's shiny clean, and then you can move on to the next one. It's pretty cool. This just kind of talks about what I mentioned earlier, and you saw in one of those first videos. It takes more strokes than you think, and so a lot of times we're scaling with the hand instruments or the piezo and thinking that it feels clean, but just because it feels clean, there's so much more calculus that can be left behind. So again, enamel on the right, cementum kind of in the center, and then the CEJ is kind of right at the top there.
And Danielle, Rebecca Rios asked, this is remarkable. In this video, was the calc cleanup sped up, or do you really move that quickly?
Oh, I moved that quickly. Yep. Nope. This
Mhm.
is just a normal video.
That's great.
And the adaptation, I always think I have good adaptation, and then I watch my videos and I think, oh, just angle it just a tiny bit and you can get it. Like it's right there. It's 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 more interesting than you think when you think you have the perfect angle. So you just have to kind of manipulate your angles to be able to get them. See, there's still a couple little tiny specks there. You just keep going
Karen
back to get it.
with PerioView was very gracious enough to open her doors to me, and I went into their offices here in Phoenix, West Valley Periodontics, and her husband are the, co-founders of PerioView, and she stressed that. She was like, you think you're adapted, but if it's one thing that the endoscope has shown proven to her and anybody who starts to use it is, are you really adapted
Hmm.
properly, to the tooth surface? And so many are not, is what she noted. So that's definitely stuck with me.
And it helps you to become a better clinician, understanding that you are.
Hmm.
Excess cementum, I don't know if anybody has ever seen this, but it can look like calculus on the x-rays. A lot of times it doesn't because it's a different color. But if anybody wondered what excess cementum, usually from heavy clenching, looks like, it's this white part in the middle of the screen. Um, and so that actually I cannot remove. And so that is when a flap is indicated, and Dr. Moulton can remove that surgically, so the pocket can heal. Fracture, this fracture. So everybody can probably see the crack is, can you everybody see my mouse? I think, Elaine, can you
I
see my
can.
mouse?
Yes.
Okay. So here's the fracture right up at the screen, and we actually use a blue dye. So that way, similar to a disclosing solution, and the blue dye will fall into the fracture so that when I go down there with an endoscope, I can see the full extent of the fracture and how far and how deep it goes in. And that helps Dr. Moulton. I'll obviously have him come in to determine the extent of the tooth and then give the patient the news because, as many of you know, sometimes you're unable to keep a tooth depending upon the extent of the fracture. That one's pretty cool. So furcations are one of the toughest spots to keep clean. That's one of the areas that perio patients struggle with. It's one of the areas with deep cleanings that being able to utilize the endoscope has been a game changer for patients keeping their teeth. I would say these furcations are where all the bacteria hang out. This one is already clean. I should have taken a video before I removed all the calculus, but the whole hood, I call it the hood, but the whole like fork or hood of the calculus was completely full with, excuse me, of the furcation was completely full of calculus. There's a little excess cementum in the center there that I usually smooth that out. That way that gum tissue can get that reattachment. And to me, I understand what I'm looking at. So if anybody has a question, like I know it's kind of strange to see these new videos. Um, this one is an implant. And then we just have about 10 slides left. So this is really helpful for the threads of the implant um, to be able to identify, is there calculus? Is there cementum? Is it just biofilm? Um, in a perio office, that is one thing that Dr. Moulton treats is individual implant cases, and the endoscope is super helpful for that. And then clinical benefits. So in the end, we talked about in the beginning, it's another tool in the toolbox. So anything you can do, whatever niche you have in hygiene and how you help your patients, is amazing. So just because you don't have an endoscope doesn't mean you're not helping them. But if you have a specific patient that isn't healing and they just want more answers, then you can find someone in your community, hopefully, that utilizes an endoscope if you don't. And so I'd say being able to deliver a higher level of care to patients, I that fulfills my I guess that fills my bucket. That like fulfills my passion for what I do. And if I didn't have that opportunity, knowing the technology, or if I was on the other end with you guys watching this, I would say, wow, there's that one patient and they're just so frustrated and I've exhausted all of my resources. I think I want to find someone in my area that utilizes the endoscope. That way, that one patient, can go get the information and decide if it's right for them. So, it gives me confidence during my periodontal therapy that I am doing a great job and that I will have good success with being able to help these patients that come to a peri office because we're the end of the road. So when you guys are doing an amazing job and doing everything you can for the patient, and you're not able to get them to a healthy, stable point, and you send them to me, I'm able to provide that higher level of care. And I feel like I have a lot more confidence because I'm using the endoscope, because I'm not just going to do the same deep cleaning and hope that I'm removing everything. I can be more meticulous and be very careful to efficiently remove the calculus with preserving gum tissue. That's another thing I think I skipped over in some of these other slides, but um, because I'm being very delicate in removing just the calculus, I am not completing unintentional curettage, and I'm only removing the calculus and then I'm moving on. I'm not overscaling and I'm preserving all those root surfaces.
And to add to that, Danielle, you did say something to the effect of, in the beginning, you talked about a treatment goal, like something to the effect of you want minimally invasive care. You want to avoid
Mhm.
excess tissue trauma of sorts, and then focusing on the end result, which is what does healing look like? What does a good treatment outcome look like? And so there's a question by Andreas Steenberg. Uh, have you ever come across calculus that was so tenacious you could not remove it? And that's speaking to the confidence, booster, or what takes away our confidence as hygienists is not being able, to get that job done. So have you ever come across calc that you could not remove?
No, I would say yes, early in my career before I used the endoscope, because I would think it was removed, take an x-ray, it was still there. I was frustrated. I felt like I was adapting it. I was using hand instruments, specialty instruments, piezo. I couldn't remove it. But with the endoscope, I'm just using basic finger, I guess, ergonomics, and I'm just removing it by sight. And so I'm not having to scrape and use cutting edges to efficiently remove everything. So I would say, real life answer, have I removed every piece of calculus on every single patient? No, because no hygienist is perfect that ever uses the endoscope. But I would say 95 to 98% of the time I do, and that 2 to 5% that I don't, I tell the patient, I can't see all the way. Your tissue is very unhealthy. In this part, I don't say that. I say your tissue is very inflamed and I don't have direct access. I can't confidently tell you that I've removed all this. So if this pocket doesn't heal or at your 3-month follow-up, perio maintenance cleaning, if this area still has bleeding, we'll need to do a retreat in this area. And I'm just honest with them because I don't want to feel like I left it behind and they think I did a good job. So there's probably spots where I have left it behind, but I feel like a lot of my patients have healed and have pretty good success. And when that bleeding goes away, usually that's that sign that that pocket is healing well.
And I'll second that. I tell the patients many a times, and I do not use an endoscope. This is round one. We are
Yeah.
revisiting, and the less, I mean, depending on how it goes, about 45 minutes into an hour and a half, SRP, when that calculus is winning. And
Mhm.
it's like, Miss Smith, I'm going to tell you, we are going to numb you up again the next time you come for your perio maintenance. Like, what can you
Mhm.
do? I'm not trying to be Superman. Like, I don't have the technology, and this is why I wanted to highlight you and this endoscope because it gives you the confidence to know that you are getting the job done. Love it. Okay.
And that's one reason why we actually set aside an entire morning for patients.
Hmm.
Sometimes they say you're gonna do a deep cleaning for 4 hours for just half of my mouth. What are you gonna be doing the whole time? I say, no, I just want to make sure you're comfortable. It usually does, depending upon the amount of calculus, take me 2 to 3 hours. But they say, how long is it gonna take? And I say, everyone's different, and it depends upon how long it's been there. And if it's in a hiding spot. And so I won't move on from a tooth until that tooth is completely done. And so I'm particular. And so I'll start on one
Hmm.
specific tooth and I'll clean the whole tooth and then I'll move on. So sometimes it could take me 40 minutes for one tooth for this tenacious calculus with furcations and everything. And sometimes that calculus comes off easy and it takes 5 minutes. So it depends on the individual tooth.
Have you come to know, Danielle, like the calculus quality? Can you kind of guess like how tenacious it is or not before you get start on a case?
No, and that is one very interesting thing, and that is one reason why I work with an amazing doctor, Dr. Ethan Moulton, and he is someone that is very supportive of the care that I provide or we provide for patients. Because if I block out an entire morning for a half mouth of deep cleaning, um, it's not how much extra production can we squeeze in. It's he knows I'm going to give good quality care to that patient, and I want to make sure that they're comfortable, and I want to do a great job because I don't ever want to only schedule them for 2 hours thinking it's just a 4 and 5 millimeter pocket. It's an easy deep cleaning, and then I get in there and I can't remove it because it's so tenacious. Or the other way around, I schedule 3 to 4 hours and they've got 6, 7, 8 millimeter pockets, but for some reason it comes off like butter and it only took me an hour and a half. He is very supportive in that because a lot of that time is spent with the patient educating. And then there are so many other things, which I can talk about at another time, that I do on the back end to help these patients get to their optimal health. It's not just the endoscope, like I mentioned, there's so many other tools that I utilize um, and so I'm really fortunate to be able to work for an awesome doctor.
That's great. Shanda Grange said, rock star, hygiene goals. Danielle, you
Shanda.
are hygiene goals.
And
How
you
many
know,
patients do you,
sh-
oh, go ahead. I'm
shout
sorry.
out to Shanda. She has taught me everything I know as hygienist. Make me a little emotional.
Oh my
She's taught
gosh.
me everything I know as a hygienist. So I do feel like I am a great hygienist today because of her.
I love that. And you guys, if it weren't for people like Danielle, I would definitely not be where I am. So this is why I have this study club to create access to connect with professionals like her who are really upstanding and representing our profession with integrity, precision, technology. And then earlier, Shelley Rice asked, how long do you feel it took you to integrate this into your practice? And what does the learning curve look like?
I would say it depends upon the type of, and that's it for the presentation for in terms of the slides and the videos. I do have cases, so if anybody needs to go, you're free to go. But I definitely will stay on as long as we need to answer questions. And then I do have cases if anybody wants to see those. But it depends upon if you um, are a general practice and you only have an hour for patients. What does that look like? Will your doctor give you the opportunity to go to training? Will they give you an opportunity to schedule a little bit more time for deep cleaning? So there's a lot of logistics that goes into incorporating it into the practice. And I'd say everybody is individually different. So whether you're a hygienist that started out on hand scaling and you picked up the ultrasonic very quickly, or it took you a little bit of a learning curve, um, and it took you a little bit more time per patient. I guess that's the best example of how long is it going to take me to learn this. You might pick it up very quickly, or you might need a little bit more time, and it might take you a little bit extra time to complete, I guess, to be efficient, to complete those deep cleanings. Did that answer the question?
Yeah, it takes
Okay.
it just like everything else, it takes time. It
hmm
takes time.
And And I used it when I got to the office, there was already endoscope there. And so within I think I'm guessing, I'm trying to remember the timeline, within a couple of months of being there, I already learned it. I just had to jump straight in with training on a patient that was okay having, we just gave him a reduced fee because it was a training and he was sedated so that he was more comfortable, which thank goodness because he didn't remember all the details. um, And it was just a lot of water for him as I was like learning to utilize it. But I felt like it was pretty easy. All of the skills we've learned as hygienists, I feel like if you are very efficient in hand scaling and using a piezo, the endoscope is very easy to use.
Mhm. Great. And another question, have you ever tried Hygienist for the harder calculus?
So I was recently introduced to that actually when I was with you in um, the course in Kentucky at the Oral Systemic Mastery,
Mhm.
and they had discussed Hybenix and how that can disintegrate it. And one thing that I still need to do a little bit more research on, especially because we're a perio office and a lot of our patients we treat with Lanap because we do
Mhm.
want that regeneration of hard and soft tissues. Um, and I need to understand um, a little bit more about what it does to the root surface and how any lasers can have interaction with that. And so I haven't done all of my research on, yes, it's going to disintegrate the calculus, but how is that going to help with the reattachment of the tissue? And will it have any other, I guess, interactions with the healing? So no, I don't know enough about that, but that's a good um, reminder for me to look into that.
Mhm.
Do you know a little bit about that? Have you utilized that, Elaine, or do you know of anybody that
I
does?
have not personally utilized Hygienix, but I believe it does have a pigment to it, number one. And number two, why is it utilized? I think it's utilized for the main purpose of softening the calculus or dehydrating the calculus so it's more easy to remove. I could be wrong on that, but if
I
that
think
is the
so.
sole rationale, I already utilize the diode laser in such a way that does that. So in my philosophy, using less is more, but
Hmm.
if it has a clinical value and a therapeutic value and or a mechanical value, meaning it's going to be easier to remove the calc, then absolutely. And if that's a question, I definitely will seek it out and let's highlight a speaker who utilizes it and let's all
Yeah.
learn together. So thank you for that question. And then earlier there was a question on what is the cost of the endoscope?
That is a good question. I was going to figure that out before this webinar, and I totally forgot. I do know I did look up the cost of what we charge per quadrant to utilize the
Mhm.
endoscope. We charge $321 per quadrant. I'm sure other offices charge something different, but we want to make sure, in addition to the deep cleaning that we are, or the SRP, that we are having the patient um, pay for our skills and for the sheath because usually it's only one sheath, but with any disposable, sometimes you might have to have two, or they come back for a second visit and I might have to use a second one. So at about $100 a pop, we want to make sure that we're not losing money and they're paying for that additional service. So we don't give it as an option, but that's because we're a perio office. We let them know it's a deep cleaning with the endoscope, and they say, "Do you have to use that?" And we say, well, that's how we're able to see underneath the gum line to ensure everything is removed. And then they don't have any, I guess, pushback.
Yes, and so Ms. Karen Aguilar of Periscope, she just put in the chat the Perio View is 29,900, so about 30K. And she did share with me that all of her hygienists, I mean, it's beautiful to walk through the halls of her practice, seeing an endoscope and a laser in every room. And they are charging a little more than that per quadrant, and they are getting it with no questions
Okay.
asked because the training, the excellence, the philosophy, the value. So I see this all the time when it's like, wow, that's an expensive piece of equipment, or whoa, you're charging the patient that much. Oh, it's an upsell. Technology has a place, and if we
Hmm.
are properly educated and trained, that's where the confidence comes in. The value is there, and being able to relay and verbalize that value to the patient is everything. Because when I think endoscope, I think like prostate. When, men,
Mhm.
what will men think when they hear
I was thinking the other
endoscope?
direction, but that direction works too.
you know? And so it's like people have an idea, or when they hear laser, they get scared. They think pain, discomfort,
Mhm.
luxury, not a necessity. So all same things apply, when it comes to incorporating. And please, Danielle, I'd love for you to, and so just housekeeping stuff. I will be awarding 1.5 CEUs for this. So if you had to leave, or if you need to sign off, this will be uploaded to our YouTube channel. So if you're watching for the very first time and you're on YouTube, thank you. You will get 1.5 CEUs for this. If you're watching live now, you will get 1.5 CEUs for this time. Okay, so thank you guys for staying on. And Danielle, if you have time, or if you want to create a part two, we can, but I'm dying to see your cases. So
Yeah.
if you want to share like part two, please, by all means, and we can just keep
Oh, sure.
going.
There's a couple of slides, and so I tried to get as much information as I could, I guess.
Hmm.
Um, so this one was an example of deep cleaning with the endoscope and extractions. Um, I think moving forward or in the future, I can put a case together and have the specific x-rays and charting, and then maybe of one individual tooth with quite a bit of bone loss, and then find like a video of that too. So I could be more mindful of knowing like this is a 9 millimeter pocket. This one has a lot of calculus, and then I'll take a video specifically of that one so that I could share that in the future. And I thought about that while I was making this, like, oh, that would have been a good idea. And so in most cases, we try to preserve tooth structure and try not to recommend any extractions, except for when that's the patient's choice. In this case, it was the patient's choice because she could not afford laser. It was just something that was not in her budget, and we still want to be able to help patients. And I say afford laser in a different way instead of like laser bacterial reduction. I'm talking about LANAP.
Yes.
And so the deep cleaning with the microscope was the bare minimum of what she could um, afford. And so one of the, looking at her initial, I'll go back to the saliva test, but looking at her perio pockets for the success of her um, long-term perio health, we gave her the option of removing 2, 15, 17, and 18, and 31. Because of the 8 millimeter pockets in between 14 and 15, some of those 7 millimeter, some of the different deeper pockets, just because you can access them and keep them clean with a microscope doesn't mean that, or an endoscope, doesn't mean that the patient can always keep that clean, especially if you're not getting some of that tissue regeneration from the laser. And so in this case, it was recommended, or we gave her the option of having those out. And she is doing great, and she doesn't miss them, and she chews fine, and she is super happy and able to keep things super clean. So the amount of calculus that she had was one of the reasons why there was so much bleeding that you see on the left. Almost every single spot was bleeding. Um, going back to her saliva test, again, a conversation for another time, but saliva testing, I feel, is one of the most important things that you can do as a clinician in a general practice to get the information. Because as a patient myself, I would hope that someone would give me the information and let me make the decision if I wanted to be proactive and reduce the bacteria levels, or if I just wanted to monitor and keep an eye on it. So saliva testing is really important in our practice because, again, it's another tool in the toolbox to be able to um, treat patients more comprehensively. So with how high her bacteria was, she had upper measurable limits of AA and PG, which we all know is like the worst bacteria. We let her know without extracting those teeth, even with an endoscope and confidently removing everything, there is not a great chance that you'll be able to keep those clean and as efficiently help you to keep these bacteria levels down long term. So by utilizing the endoscope, deep cleaning, this was systemic antibiotics also in combination with her treatment and those extractions. I think I took this test 3 months later. I didn't write the dates on them. we were able to get completely rid of her AA, PG, TD, and TF, which was absolutely amazing,
Wow.
and help her to become more stable. So that was pretty cool.
Danielle, do you do the reveal or is this the patient in the doctor's chair? Like, when do you have that conversation? How long does that conversation take? What's the skill level on that conversation?
Tell me about a little bit more about what you're asking. What do you mean about what conversation?
So the question is, do you do the reveal or is this the patient in the doctor's chair? The reevaluation, excuse me.
Oh,
I'm like
oh, sorry.
revealing the
Yes.
results of the
Oh,
bacteria.
yes.
Sorry.
So uh, with the perio patients, Dr. Moulton is a part of that initial exam with me, with the comp perio exam in the beginning. And then if during treatment, he'll support and complete his portion if it's LANAP. Otherwise, after that, it's solely the hygienist. So I will go over all of the progression with the patient. I obviously can't diagnose, so he is always a part of anything that's diagnosing or letting them know that they need additional treatment. But being able to go over the results, how things look, reviewing everything with the patient, that's me one-on-one with the patient. So
Mhm.
with the post-op visit, with the perio maintenances, I'm having that sole conversation. And because we're a perio office, we do exams when needed with the patient, and Dr. Moulton is a part of that. But no, I do the majority of all these conversations and discussions with the patient.
Mhm. Would love to have you back on more of this case review and what your thought process is, A to Z. Um, Case
Yeah,
selection, how you guys determine a tooth is palliative, hopeless, needs to be removed, what your goals
hmm,
are with LINAP. So looking forward to
yeah.
that.
This is the last one, and I know it's getting late and we probably all have to work tomorrow. So I'll just briefly go over this one. But this was a really awesome case because I almost said her name. She is an awesome lady, and she was actually recommended to have all of her teeth out and to have dentures. And trying to remember her age, she's in her late 20s. And she just said that she didn't take care of herself and that she is at a point in her life where she is ready. And part of the thing that I incorporate into our practice, and I've had skills from the Blatchford training that I've had, the Blatchford consulting, is getting to the patient's why. Why is it important to you to keep your teeth? Why don't you want dentures? What have you experienced through conversations with other people? You know, like getting to understanding on an emotional level why it is they want to move forward with treatment. And that's one of the reasons that I have really good success in being able to treat patients is because I feel like that I don't ever have to sell dentistry. I just get to the emotional level of their why, of why it's important for them. And then I let them know how I could help them and how I'm on their side. And then it all just flows and they accept treatment and I help them well the best that I can with the tools that I have and I support them along the way and I'm like a partner in their journey and I feel like that's why I have um long-term patients that even when I say okay you're ready to go back to your general dentist you don't need to see us anymore they say well can't I just get my cleanings with you and I say yes but we have to alternate because you need to go back to your hygienist um and so yeah I don't want to get too much on a tangent on that but I really do have a passion for helping patients that someone else thought might be hopeless and said, you just have to have all your teeth out. So I feel like there's always options. But she had significant bone loss. Um, and from, it's a little bit hard to tell. I didn't have time to like get screenshots of all this CT scans. But going from just short 3 years, the amount of bone regeneration and tissue regeneration that she had was absolutely amazing. I'll show you her perio charting. So on the left-hand side is her before picture, the right-hand side is her after pictures. You can kind of see the change in inflammation on the bottom from the left to the right. Because she had significant bone loss on the top and such mobility, we recommended a splint, an extracoronal splint, in order to stabilize those top teeth. And we let her know, will you be able to keep all of your teeth the rest of your life? We don't know. This will give you the best opportunity to stabilize those long term just because she didn't have very much root surface, excuse me, root support. So this was her initial perio charting. Um, and again, as perio, whenever I was in a general office and I would see something like this, I'd say, "Oh wow, you need to go to the periodontist." Well, guess what? Now I see it and I think, "Oh crap, I have to do that." So um, sometimes it's a little overwhelming to see these like 7, 8, 9, 10, 11, 12 millimeter pockets. But then I think it's okay. I have an endoscope. I can see to the base of this pocket. And if I can't see to the base of the pocket, then we'll let the patient know and we'll either complete a flap or we'll let the patient know we need to bring them back when the tissues are shrunk, they're more healthy. And then I can go back in with the endoscope and I can see to the base of the pocket. So it's very amazing and cool to know that there is technology seeing this paracharting. And instead of saying, let's remove all these and do implants, to say, let's treat you with a deep cleaning, with the laser, so LANAP, and let's use the endoscope. Let's use a tool that will help us to ensure that we could get in all these furcations. You guys see all those furcations on all those back teeth. I mean, these are very difficult spots for her to keep clean. And these initial measurements were probably, pre-calculus. And so they're probably a little bit deeper during the actual cleaning visit. Um, but this is 1 year post LANAP. So is she back to perfect? I would say it is extremely stable. So going from those 10s, 11s, a lot of those teeth. I think she did lose one tooth. No, she had that out before. Yeah, the wisdom tooth. She had 17 out. But besides that, we've been able to help her, stabilize these areas. And because of the amount of bone loss in her bite, those 4s and 5s, while they have light bleeding, they're pretty stable. And so I'd say this is a pretty big success case.
Amazing.
I didn't get a chance to incorporate her saliva test, but she had a really another amazing saliva test where she followed a lot of the protocols and her bacteria was in the upper measurable limits, PG, TD, TF, all the really bad red complex bacteria, and being able to help support her immune system and bring those bacteria levels down, along with her systemic health, was what helped her to get back on track. So. And I know this is going way over, so I'm not going to talk about it. We do comprehensive care. Lots of different things go into treating patients. We work with their medical doctors to get complete labs. This is an example of the vitamins. We look at, always check A1C, super important, usually a contributing underlying factor. Um, and then saliva testing, super important. So being able to treat patients however you feel that you have the tools in your toolbox at your office is going to be the best that you can do. And if you feel like you want to help the patient more, then like I mentioned, just find someone that has an endoscope in your area. Or I put Karen's information on here. Email her, see who might have the endoscope in your area. There, she might have contacts of someone that live close to you that have an endoscope that it's not on their website, so you don't even um, have access to find out that information. That way, if it's not something that your doctor is ready to incorporate into your practice, you still have that additional step if your patient wants more answers. So
Thank you so much, Danielle. Everybody who's still hanging with us, thank you. You guys are awesome. And I would love to host you, Danielle, for a part two. I will send you an outline. I have
okay.
so many like questions, ideas. Like I think even just as a mentor, how can I improve what I'm doing with what I have? How can I improve knowing when to send a patient to perio? How can I select a periodontist that is going to treat to the optimal standard of care? Because not every perio office has the technology and the equipment, to exceed what we can do beyond a general practice. So that is
Mhm.
also why I really wanted to highlight you. So thank you so
Yeah.
much. It's very, very inspiring. And I do appreciate you guys for coming out and joining the study club. And I hope you'll join us again for our future courses. Again, we are on dentallaserintegrations.com webinars tab. You can find this recording as well as our YouTube dental laser integrations, and I'll be sending you guys more info.
Thank
And
you for listening.
thanks, guys. I'll stay on for like a minute or two more as people start to trickle off. And Miss Danielle, how much time do you have before you have to go to your other job, which is being a mama? So, how much time do you have before you need to clock off here?
If any questions or anything you want to talk about, I'm fine. My husband has the kids, so he's keeping them busy downstairs.
I love that. I love that so much. So, there's a couple of things that stood out to me. Like when you started off, you said, I found a passion. And that resonated with me because I think we all want to do more. I think we all, after we've practiced for a year, 2 years in, you've been around the hygiene block. We want to be challenged. I think that's what's great about dental hygienists. Like we are looking for a challenge. And if we don't have that, a supportive environment, a growth environment, I think that is truly what contributes to our burnout.
Mhm.
So, not only is it important to kind of find something that piques your interest, your passion, but it's also important to seek the skills that these employers are looking for, like
Mhm.
your boss. I'm part of Dr. Moulton.
Dr. Moulton. Mhm.
He wouldn't have hired you if he saw something particular and you said you already had endoscope training. So can you tell me what were some of the skills as you went from like general dentistry to perio? Like what were some of the skills do you think that got you in the door to a
Sure.
practice like Dr. Moulton's?
And no, I did not have endoscope training. I did learn that as soon as I started with his office. I
I see.
actually hadn't heard of the endoscope until I went to his office. I thought it was just something you get at the ear, nose, and throat doctor. I didn't know that
Mhm.
was a technology. I might have heard it before somewhere, kind of like you go to a dental convention and you hear it, but you don't hear it again. So I
Yeah.
hadn't heard of that before. But what was
So
the question of where, what kind of led me to looking into perio or looking into
yeah.
that office? Um, I think what initially drew me to the job specifically was the type of person they were looking for. Again, I think it goes back to those emotions of I wasn't looking for what they were going to like. I guess I wasn't looking for specifics in the job. I was looking for the personality of the office within the resume. No, not within the resume, within the job posting. So, what type of person were they looking for? What type of patients did they treat? And that's what attracted me to the job posting to begin with, because, and I keep saying this over and over, but I have a passion for treating patients comprehensively. And I wasn't always
Mhm.
like that, but along the way, each job and the different types of courses and webinars and continuing educations and being able to travel to conferences, that
Mhm.
has built my passion. And so um, I kind of read between the lines, and that's what attracted me. And then when I found out it was a periodontic office, I thought, oh, um, I never thought about working in a perio office, but I wanted so much to help patients on the same level that I thought, let's talk to him and then see where it goes. And that's how I actually kind of fell into it. So,
That's great. So essentially, you have a heart to continuously learn.
hmm. Yep, agreed.
Because I I know that we all, wake up and intend to do our best, but sometimes we get to a point in our career where we really can't take on much more. Maybe we're raising kids, maybe we're taking care of sick family, maybe we're working in an environment that kind of stifles. Cortisol is contagious. And so
Hmm.
I'm a big proponent of being in an environment that is safe and, um, allows you growth, allows you grace to make a mistake, ask questions, send you to courses, investing in you. And I think that's the one quality that I look for. Like, when is the last time you invested in the team? When is the last time you sent them to a team training or created a learning opportunity for them? And that is something that's really important. And I met you with your boss, right, at Oral Systemic Mastery. And he is obviously that type of employer, that type of boss that believes in investing in his team. And so also leadership, like how much of the team do you have to kind of guide, support, direct, help? What does that look like? What does a leadership role look like as the only hygienist in a perio practice?
Yeah, I think that was a big transition. Not only being the sole hygienist in a practice, but being the
Yeah,
sole hygienist in a perio practice, because you don't have anybody to bounce ideas off of, and
yeah,
you do need a good support system. Because, for example, when you're in a general practice, a lot of times you only have a certain amount of time, and you have to do perio charting by yourself. I do need the support of my team, and I do appreciate all of the girls that I work with, because they know that if I ask for help, I truly need it.
yeah,
Because you guys saw some of the perio charting. I mean, you can't
yeah,
remember those numbers and type those in and hit next to get the bigger pocket.
absolutely.
Um, so yeah, I'd say one of the you had mentioned your employers believing in you and investing in you. And that's one thing I encourage everyone to talk to your boss about is, hey, I saw this really cool course that came up. It's in another state. Would you be willing to either pay for me to go to invest in our practice, or would you be willing to invest in 50% of it and I'll pay for it? There's always a spot that you can start and ask. And what's the worst they're going to say? No. You say, okay, then can I take the time off and can I go? Because you never know when that conference will make a big difference in your life, and you'll meet someone like Elaine and, be able to share your information that you learn with the next person to be able to empower them to move on and, um, I guess move towards their passion or help their patients more. So I would say definitely speak up and ask. I used to be a very shy, quiet person, and I'd say as I learned along the way in different offices, and like I was very fortunate to have offices that believed in me, I did ask. Sometimes they would send me to courses, but then sometimes I'd say, this one could have a good, what is it, the ROI, return on investment.
Yep. Return
If
on
I go to
investment.
this course, I feel like it could increase our production if I bring this knowledge back, or I can use this product. Would you be willing to pay for half of the course? And a lot of times they said, no, that sounds like a great idea. I'll just pay for the whole course. But I was prepared to go on my own
Hmm.
because I wanted to learn and I wanted to
Yes.
know more and kind of expand that.
Can you please pay for my course and my travel and my food, please, and my outfit
Okay.
that I need
Yep.
to wear?
Oh, outfit's
So
good.
looking at, okay, so let's say we wanted to buy the Perioscope, the endoscope. It's $30,000. Okay. Um, let's say you're charging, 300 to 400 a quad. I just did the math, you guys. That's 18 patients. So if you're a doctor listening, you should not be scared to invest in technology. What you should be scared about is having a hygienist on your team that is scared to learn and incorporate new things.
Hmm.
That's what's scary. And
Agreed.
I believe that it is scary to go out and learn. It is scary to go out into a course or a conference by yourself. Like some of us are lone rangers and we're like, yeah, I'm gonna get my notebook and my earphones and my highlighters and, you know, wear my comfy shoes and go to this thing and enjoy it and probably not talk to anybody. Like I see some of you at the conferences in your little bubble, but some of us are scared to go out there and learn something new. And I have a lot of people who reach out to me like, is there a test for laser certification? Or how much time is this going to take me out of my appointment? That is an operational concern. Like this is why I'm asking guys, what is the leadership like? What is the team support like? How does your boss regard you? Like, I don't have to ask you, Danielle, because I know your boss respects you, invests in you, and sees you like an asset. But for these practices that are, thinking, wow, I could never get that because it's too expensive, it's way beyond, or I don't have the clientele for it, I don't have the patient base for it. Did you miss that slide where she said she was digging for hours in a 4 millimeter pocket? You know, like we are missing a huge opportunity here. So, I think that if we have a part two, I would love to talk more about helping people have that conversation because we want to learn, we want to attend these events, these courses, but sometimes we need more support in that conversation. And that's,
Mhm.
we're here for that. So yeah,
And just like the dentist will invest in the bright new shiny of what they think is cool and fun for their side of the practice,
the
even
sprint
if
ray.
it's, yeah, it's like pulling teeth to even get like a new scaler. Um, if you
Yes.
just ask, it's like, I feel like it's like my kids, like, Mom, can I have this? Can I have this? Can I have this? But if you just ask all the time, the answer might always be no. But if you go about it a different way and
Yeah.
really get to the emotional side of it, I keep turning back to that, but you get to the why of it, like
Yeah.
why is it important to you, and go to them and present it with that of, I found this and it would be so beneficial to our practice, or it would be so beneficial to your practice, however you want to word it. And start it out like that. It's almost a sandwich. Like let them know how it could benefit them, how it can make money, why it's important for you to go, um, and then just ask permission and just see what they say. You would be really surprised if they feel that they want to invest in you and their team. You'd be surprised. They might say yes. Probably say yes.
Absolutely. And on the other flip side of things, if you're a hygienist who wants this, wants to do more, maybe the practice you're in now is not the office that's going to do it. So you really have to meet with yourself and you have to take a look around because these years go by fast. And before you know it, technology is advancing and our clinical skills can become stagnant and outdated. It really can. And, I mean, I teach laser certification on a weekly basis and from all people from all backgrounds, this is something new, and I'll stop there. Like I won't get on my box, but I wanted to add to what you said earlier. You are responsible for that equipment too. So I really am like, I'm really just, I think that's so great that you're taking full accountability for the maintenance, the upkeep, the protection of that,
Mhm.
of that piece of equipment. Because
I
basically
couldn't
you're the,
imagine if it was down. I
yeah,
literally couldn't imagine. I'd have to
you
reschedule
couldn't
the
work
deep
without it.
cleanings. I
Yeah.
don't feel like I could give the higher level of care now that I am in that spot without it.
Yeah. Yeah. That's great. So, if you're still on here, thank you guys. I'm so grateful that you guys are participating and just listening to these conversations, even if you're doing your dishes or serving your children dinner by now at this point. But my key takeaways were, find a passion. At some point, Danielle, you kind of tapped into that and you were seeking more opportunity and you found it. You did want more. Technology came right away. You were willing to learn it and grow at that office and who you treat. Like it just so happens that your people are coming from across the way, over the mountain and through the woods to get to you. And how great is it that they get to see you, somebody who's patient, compassionate, um, values educating that patient. You said you guys treat anywhere from low SES, low socioeconomic status to, people with insurance and beyond. And being able to give people access to care no matter what their budget is, that really, really resonated with me because when we teach laser, a lot of offices are using it as a profit center. And I don't like to lead with profit first because if you do, it's going to be a long day. Like it's beautiful when you get to the other side of treating a patient and seeing their healing outcomes, etc. But that conversation is not always easy. And some of these patients need a little bit more time and consideration and TLC to get them to want to invest with us, with you, with your technology. So having somebody like you, Danielle, that is patient with them, educates them, spends the time to show them their saliva test, helping them understand why it's important to get medical support, like the cross back and forth between the medical. Like imagine having to get a deep cleaning that's like 4 hours long, but then you also have to go to the pharmacy, and then you also have to go to your medical
Hmm.
doctor and get a blood test or a workup. Like it's a lot of commitment on the patient side, and I don't think I, I'll speak for myself. I didn't come into technology driven practice really thinking about what the patient has to go through, but it
Yeah,
really makes a difference.
I probably spend a good 3 to 4 hours with the patient, whether in person, on the phone, text messages, looking at their labs, analyzing their saliva tests, all of that before even the deep cleaning. And then I spend so much time with them in the deep cleaning. We're almost like buddy friends afterwards. It's like by the time they've completed that deep cleaning, and then I have that follow-up text, whether I text them that night to see how they're doing or check with them the next day or, wait to the follow-up depending upon the patient. Um, I've invested so much time and I almost feel like we get to know each other because we've spent so much time together and then we have that trust.
Yes. And more can be said about when they go back and forth. And I've worked in perio where they're like, oh, we don't want to step on the toes and bite the hand that feeds us, where we are, you know, doing more treatment than, without allowing the general practice the chance to do it. That's a whole
Hmm.
nother conversation, which I can't wait to have with you and with our study club. But other key takeaways, I want to know like what you're looking for in healing outcomes, like what's the expectation of this? I mean, so much more, but definitely would want to host you in a part two for that. And
That would
then,
be awesome.
yeah, those were all my notes. Thank you so much, Danielle.
Awesome.
So
Thank you,
grateful
Elaine.
for you. Thanks,
Well,
guys. We're gonna
thanks.
sign off. Oh, wait a second. Oh my God. Whoever is here, the 10 of us that are in the chat, what were your key takeaways? Please share with Danielle because this is her first time formally presenting. And
Oh,
I
yeah.
think you did a phenomenal job.
Thank you.
Honestly, a beautiful job. You really did. Um, and so if anybody had key takeaways, can you please let us know? Because feedback is so just so well appreciated. Especially it takes a lot of effort and time and nerves for some of us to get up here and present these things. So please, if you have any key takeaways from or would love to hear it, key takeaways. And then if you have any other questions you want Danielle to address in a part two, or any
Mhm.
other perio and technology related content that you are interested in, please let us know. And we will work on it. And Miss Shonda Grange, passion is priceless. We really are our patients' best advocates. Yes, we are. Okay. And Miss Karen says, you did awesome, Danielle. You prepared and you did great. Yes. Um, Not related, but related. I don't know if you guys are following the the Lindsay Clancy trial. It's a hideous situation that she's being tried for, but it's also a question of medical malpractice. And it's very fascinating that they have a slew of doctors and nurses and just various medical providers being questioned on their documentation, their integrity, their rationale. So it's very, very interesting. And someone like you, Danielle, I think would be like absolutely wonderful to just share with us, your thought process on how you and your doctor work together to select cases. Why not? And that is, I think, what we are really going to learn from you in a part two is what I would want to see. Um, and how you document things and how you show patient their progression and follow up and review because little things like I hear from people who do saliva tests in their general practice. Oh, we don't have time to go over the results. You don't like,
Then you shouldn't test. Oh, really?
okay, so like there's a lot of this and that. And so there's always two sides to the coin. and then there's the side of righteousness. And so when Shonda said patient advocate, that's exactly what prompted me to think about these the one nurse that stood on the trial stand, and she, you could tell that she was an advocate for the patient. And that's essentially what we are, an advocate for the patient. So doctor goes in there and he's saying all these things to the patient, and they might be so intimidated by him or her, or maybe the language they use. I'm sure your doctor speaks very eloquently, but then it's like sometimes patients are not really hearing, and then you come in and you reiterate as that patient advocate, and you open up the dialogue and continue it more. It's just a beautiful relationship that I'm sure you
Mhm.
have. And I'm sure we as hygienists in general have it as well. But it's great to hear from you.
Mhm.
Somebody asked, Miss Karen asked, what is the trial about? I can't even say. Just please look it up. Lindsay Clancy. She committed a crime, and essentially the trial is a question of was there malpractice or was there malice? So it's very interesting. So to be continued. To be continued. Thank you. This was a really informative presentation. Thank you, Marvis. Thank you so much for your comments. All right, guys, if you're watching on demand, I appreciate you so much. Please watch from home, or listen in your car. Download the slide deck. Miss Danielle will make the slide deck available to us for download. The videos will not be available, but the slide deck will. And please take a time to go back and watch this if you are. On-demand participants are getting 2 CEs for this, and to obtain your CE, it will be in the show notes, as well as, let's see, as well as you can email info@Dental Laser Integrations, but how to obtain your CE will be in the show notes on our YouTube, Dental Laser Integrations, and we'll be sending that out. Thank you guys so much. We'll end this now. Thanks, Miss Danielle. Good night.
Thanks, Lynn.
You did
Good night.
beautifully. Talk to you soon.
Bye.
Thanks, everybody.